When I say surgical hypertension, what do I mean? As you know, in the US of A, there are millions of people who have hypertension, but most of them have what we call essential hypertension. We do not know why they have it. We do our best to keep them alive with medical treatment. But hiding among those millions of people with essential hypertension, there is a tiny handful of patients whose hypertension is secondary to another disease that can be cured with an operation. And that is what we call surgical hypertension. And I'm going to review actually 4 specific entities with you. So let me begin with the first of those. A 45-year-old woman comes into your office for a regular checkup. On repeated determinations, you confirm the fact that she is hypertensive. When she was in your office 3 years ago, her blood pressure was normal. Laboratory studies at this time show a serum sodium of 144, a serum bicarbonate of 28, a serum potassium of 2.1, and the woman is taking no medications of any kind. Now, this complete description identifies hyperaldosteronism, most likely an adenoma. However, let me focus on the key findings for you. If you have a lady recently found to be hypertensive, who's not taking any medicines, and you find a very low serum potassium, that should be your clue. You should think immediately of excessive aldosterone production. I make the point that it's important that she not be taking medications, because if you were to look across the board to all the hypertensives who have a low serum potassium, most of those are people who are on diuretics. Because they are on diuretics, they have a low potassium. But if a lady is taking no medications and you realize recent onset of hypertension, low serum potassium, you think aldosterone. Well, obviously, what are we going to measure next? Aldosterone. But those aldosterone levels are not meaningful unless we also measure renin. Because you and I are constantly changing our aldosterone production to meet the needs of the moment. Like right now that I'm standing up in front of a camera, if you are sitting down looking at this tape, I'm making more aldosterone than you, because in my standing up position, I need a higher blood pressure than you need sitting down. And if you were lying down, you would be making even less. But the normal fluctuations in aldosterone production are mediated by the renin-angiotensin system. So that if you see high aldosterone with high renin, that's meaningless. That's normal. But if you see high aldosterone with low renin, that's abnormal. That, gives you the diagnosis. We then want to know further, is this hyperplasia of both glands, or is this an adenoma? One way, and there are a number of other ways, but one way we can make that determination is in fact to resort to the known variation on aldosterone production depending on position. Because when the problem is hyperplasia, there is still a normal response to postural changes. So if we repeat the determinations with the patient standing up and the patient lying down, and we realize that the patient responds appropriately to the different posture, even though there is a high aldosterone with a low renin, then it's probably a hyperplastic phenomenon that is best treated medically with aldactone. But on the other hand, if there is no proper response to the postural change, then the culprit is probably an adenoma. And then we proceed with images of the adrenal gland, a CT scan, perhaps an MRI, and then you will see the adenoma. These are typically small adenomas, 1.5, 2 cms. And then obviously resection of the adenoma will cure the problem. Let me move to the next, vignette number 2. A thin, hyperactive, 38-year-old woman is frustrated by the inability of her physicians to help her. She has episodes of severe pounding headache with palpitations, profuse perspiration, and pallor. But by the time she gets to her doctor's office, she checks out normal in every respect. When you hear that description, you should suspect a pheochromocytoma. Pheochromocytoma we see more commonly on women than men. They tend to be relatively young, like this one. Pheochromocytoma has two modes of clinical presentation. Some patients of pheochromocytoma have hypertension all the time. Those, however, do not lend themselves to a good examination question because there'd be no way for you, if there is hypertension all the time, to be able to suspect a pheochromocytoma. But the other presentation for pheochromocytoma, the one depicted here, is so characteristic because it comes in attacks, in spells of hypertension. The patient is not hypertensive all the time. All of a sudden, the tumor makes a lot of catecholamines. The patient has this horrible attack with the headache and the palpitations, and she thinks she's going to die. If you were to measure her blood pressure right there and then, it would be 300 over something. But unfortunately for the patient, by the time she calls the doctor, the visit is arranged, and she shows up to be checked, the attack is over. The attack has passed. Now her blood pressure is normal. Now there is nothing to be found. You get this characteristic description. So what do you need to do on this lady? And this is a point that I made earlier when we were talking about the carcinoid syndrome. If you're going after the abnormal presence of a substance in the blood, but it happens in an episodic manner, not steadily, you're not going to determine it by measuring that in the blood, because you would have to be very lucky and do it at the appropriate time. But if you do it 24-hour urinary collection, then you collect the breakdown products no matter when they happen during the 24-hour period. And that's what you do here. So you do a 24-hour urinary collection, and then you look there for the breakdown products of the catecholamines. Metanephrine, VMA. If those are elevated, you follow a CT scan of the adrenal glands. Pheochromocytomas typically are pretty large tumors. I would say the size of a fist or the size of an orange. They're big things. So the CT scan will show it. And then surgery is eventually done. And I might point out that the hero in that operation is the anesthesiologist rather than the surgeon. Because during the manipulation of a pheochromocytoma for the surgical removal, there will be a very high risk of sending a lot of catecholamines into the blood, perhaps even leading to cardiac arrest. So the anesthesiologist does very careful pharmacological preparation with alpha blockers and titrates them during the operation so that it can be done safely. Well, let's move to another example of surgical hypertension. Vignette number 3. A 17-year-old man is found to have a blood pressure 190 over 115. You should already be suspecting something unusual here. It's not very common for someone in this age group to be hypertensive. Let's keep reading. This is checked repeatedly in both arms. It is always found to be elevated. But when checked in the legs, it is found to be normal. Now you know what it is. Coarctation of the aorta. If it hasn't already been done on this question, start by asking for a chest X-ray. Because anyone who has lived to the age of 17 with coarctation has developed enormous collateral circulation to feed the lower half of the body. And that collateral circulation includes big intercostal arteries that have eaten away the lower edge of the ribs. They have a very characteristic scalloping pattern on a plain chest X-ray. But then, of course, you also want to look at the aorta. And in an earlier age, the only way to look at the aorta was with an aortogram, an arteriogram, an angiogram. But nowadays, the spiral CT that we have already mentioned, apropos of traumatic transection of the aorta, apropos of pulmonary emboli, The spiral CT of the chest is very good at showing you the aorta. And then obviously a surgical correction of the problem needs to follow. And the last entity we're going to discuss can come in two different ways. So there are two vignettes that I'm going to read, and then we're going to recognize what is peculiar to both of them. A 23-year-old woman has had severe hypertension for 2 years, and she does not respond well to the usual medical treatment for that condition. A bruit can be faintly heard over her upper abdomen, or it could be over the flank. And vignette number 5, a 72-year-old man with multiple manifestations of arteriosclerotic occlusive disease, has hypertension of relatively recent onset and refractory to the usual medical therapy. He has a faint bruit over the upper abdomen. Both of these are examples of renovascular hypertension. In the case of a young lady, it is caused by fibromuscular dysplasia. In the case of the old man, it's arteriosclerosis. But in both instances, there is a narrowing at the origin of one of the renal arteries. That kidney receives blood at a low perfusing pressure. That kidney assumes the whole body is hypotensive and reacts in the appropriate way for that assumption, namely by making the whole patient hypertensive. Now the workup is a little elaborate and so on, but typically nowadays we begin with a non-invasive study of the renal arteries, called a duplex scanning. It's essentially a variant of a sonogram where we get pictures of the renal vessels as well as flow information. And if we identify that indeed there is a narrowing in one of those renal arteries, we typically would treat these with an angioplasty and stent, for which an arteriogram is needed, because to deploy the balloon to do angioplasty and to deploy the stent, this is done under arteriographic guidance. But let me point out a difference for you between the management between these two individuals. Obviously, the young lady who's 27 and hypertensive needs something done. You don't want to leave that young lady with this deadly disease to kill her in the near future. She's got a whole lifetime ahead of her. So she needs the workup without any question. She needs the treatment without any question. The old man with arteriosclerotic occlusive disease is another story, because chances are that the hypertension, the renovascular hypertension, is not the only problem he has. Arteriosclerotic occlusive disease is a systemic disease. It may be that his coronary disease or his cerebrovascular disease or his aneurysm of the aorta or any of a number of other manifestations of the disease might be the more important threat to his life than the hypertension. And so there has to be more judgment involved in deciding in the old man with the arteriosclerotic disease whether we in fact would even work up the hypertension, the renovascular hypertension, and treat it. And that brings us to the end of the chapter on surgical hypertension.